Good evening, everyone, and welcome to this week's Amrita Pan India ILD MDM. And today we have 7 interesting cases, one each from Rajan sir, Ramnathan sir, Sonia, and Prabhu Desai sir, and 3 from my side. Bhavin sir, Dr. Bhavin Jankaria will guide us for radiology. Dr. Sandeep Surendran is a rheumatologist expert. There is no pathology as such, to the best of my knowledge, but Dr. Ritu was supposed to be our pathologist expert. We are very grateful to Professor Athol Wells and Professor Sonia Denov for joining for our meeting, as well as Dr. Rajan, Prabhu Desai sir, and Murli Mohan sir. But unfortunately, Murli Mohan sir could not be with us today because he has another meeting to attend. Let us start with our cases. We have 7 cases, as I told, and let me share the screen.
So this is a follow-up case. I'll start as the slides come up. We had discussed earlier in March this year, 45-year-old male who was diagnosed a month prior with an not a month prior, I'm sorry, for his stamina had come down for the last 5 or 6 years. He had an interstitial lung disease. He'd been advised antifibrotics 4 months prior to that, which means the end of last year, was not keen to start. And he was on oral steroids for 3.5 years and mycophenolate 720 twice a day since the last 2 years. He's off steroids since February. He had bilateral inspiratory squeaks. We had a BAL that I think Prahlad had got done for him. And he had an autoimmune workup, which was positive for Penicillium, Cladosporium, Aspergillus, and pigeon feathers. The whole exome sequencing was negative for pathogenic variants because he had a strong family history of ILD, very strong. Next slide. And his lung functions are like this. This is the most recent lung function. He also visited Hopkins a month ago and met Sonia. And this was the vital capacity in the last 3 years. So his vital capacity is pretty stable, diffusion stable, but he does desaturate a little more than he did 3 years ago. And maybe, Bhavin, you'd like to just run through those slides because we'd seen them in March, and I'll just put the questions across after Sonia's review. I wanted to ask 2 pertinent points here.
Yeah. So my question is, I have not seen this, right?
I think you had slide scans from Prahlad and Zari that were sent for review.
No. But when this was presented in March, I didn't present
maybe you weren't
it.
there. Yeah, maybe you weren't there that time.
And I'll tell you why, because I know that my colleague has seen the scans and the reports. So let me just run through them, and I have a slightly different viewpoint. Maybe we can discuss that. So the first scan, which is of September 23, shows all of these ill-defined, non-branching, almost centrilobular nodules. And this is something that would, where we would pretty much land up saying that it's non-fibrotic hypersensitivity pneumonitis. And there were reticular opacities, both subpleural and bronchocentric in the upper lobes, which also fits in with that presentation. Then he came in October 24, which was a year later. And when I'm looking at this, what is striking is that I'm now starting to see fissure nodules, which I think were not mentioned there. And there are perivascular nodules here. And let's just skip to the current scan, which actually, and I'm going to remove the previous 2 so that it just becomes easier to appreciate all that, is that all of that, if you look at the coronals, let's just skip here, you can see the perivascular beading here. See that?
Right.
It's beautiful. This is classic sarcoid. I mean, as from a radiology perspective, the fissural nodules, the perivascular nodules, all of these would suggest sarcoid, and this would be a sarcoid presenting initially as an HP, which we've seen on occasion. And that's what I'm coming. So even here, all of this upper lobe stuff, where there's volume loss, is all perivascular bleeding. So that's where I am.
Okay, so that brings
Should I
a
stop
little
sharing?
twist. Yeah, that brings, yeah, please. So
Can you
that
go
brings
back?
a little twist to the tail. The next slide, Asmita. So, Sonia got, because of the strong family history, we had this a telomere length study done there by Fish Flow that they do at Hopkins, and the lymphocyte telomere length was low. The granulocyte telomere length was also low, but they didn't fall in the category of short telomere syndrome. Next slide. And so we had a working diagnosis of familial pulmonary fibrosis with an HP pattern on mycophenolate now for a year, oral steroids, stopped since 4 months, stable vital capacity, reluctant to use antifibrotics, but is now on nintedanib because of the familial issue. And he was counseled on transplant by both Sonia and by me. So now, of course, I'd add a third question here. The first question would be, should we cut back on the MMF dose, Sonia, based on this TLT report? Should we apply for compassionate basis use of Narando, which we have now got approvals for over half a dozen patients? That's my question. And Sonia, in light of what Bhavin said, any new thoughts? Should we biopsy here? Should Prahlad hadn't done a transbronchial biopsy, I think,
No.
done a BAL.
Yeah. So a couple things. So if we can go back to the coronal sections of the CT scan. The other thing that is pretty notable, at least when I looked at the imaging, is that he looks like he almost has a PPFE kind of pattern. You can see that he's starting to lose volume in his upper lobes and that he's getting more thickening towards the apex of the lung. And I mean, that's a pattern that I definitely associate with familial ILD. Let's see, his most recent scans. Yeah, if you can go to
So
about mid.
that's his most recent.
So you
And
kind
yeah,
of
you're right. There is.
you can almost see how he's starting to pull up the fissures and that he's starting to get a much more bumpy appearance in the at the apex of the lung. And that pattern is something that we've seen a lot with our patients who have familial ILD. It's again, when we see odd imaging patterns, the thing that we think about is whether this is familial. And I think that the point that Bhavin made was very good, which is that these can look like anything. So you can have it look like an HP pattern, you can have it look like a sarcoid pattern, but the fact that he has multiple family members really trumps all of that because it essentially says that whatever the pattern is that he has, it is being driven by some sort of genetic risk factor. And so, one of the things that I think that we have to think about is essentially sort of what is his trajectory going to be? This is a guy who's otherwise quite healthy and is very young. And so, the problem that we've seen in patients who have this sort of PPFE sort of pattern where the upper lobe seems to become more heavily involved is that they don't become hypoxemic until very, very late in their disease. And often what will happen is that they'll start to develop spontaneous pneumothoraces. And so the goal we typically have with a patient like this is to, treat them as fully as we can. If he's tolerating nintedanib, I think that's fine. If he's not, then I think getting compassionate nerandomilast makes a lot of sense. But at the same time, I would favor, if it is feasible for him, and this was something that I didn't really know because I'm not as familiar with the system there, I would favor him getting worked up for transplant because these diseases can accelerate in very unpredictable ways. And again, because his pattern is predominantly apical rather than basilar, his hypoxemia is not going to show up until he's very, very far into his disease.
Sure.
And so, you know, I think that what I had said to him was that there was no need for, the urgent thought of transplant. It's not like he needed to be transplanted in a month or even in a year, but that because of the complexity of getting through the transplant program, at least on the US side, I would encourage him to kind of think about that in a sooner fashion rather than a later fashion.
Sure.
And then the second point that you brought up, which I think is also really important, is sort of thinking about, he is actually being treated as if this is either a sarcoid or an HP. And Bhavin, that's part of the reason why I think it matters less because he's, he's getting immunosuppression and he's stable, but he's not getting better. So if this were what we would kind of think of as being sort of an active sarcoid, I would have expected him to have at least had some response. And I think that part of the problem is that he probably just has a much more he has a much more vigorous fibrotic pathway than a normal repair pathway. So I suspect that what we're going to see is as we go along, this is him being treated, and you can see he's developing more and more fibrosis as he's being treated. So what I suspect is going to happen is that you're just going to watch him slowly but surely develop thicker and thicker apical caps and pull up that upper lobe more and more. And then eventually he's going to retract his his above the sternal notch, and he's just become more and more dyspneic without becoming hypoxemic.
Sure.
And so, you know, I don't think that his telomere length is short enough that it's going to be. I know that the point that you're referring to is that there was this paper from Christine Garcia's group showing this association between shorter telomere length and increased risk with the use of immunosuppression. And that was in patients with HP. This is a kind of it's kind of, so what I said to him is if he had very short telomeres, I would suggest that he stop the mycophenolate. And I said that if his telomere length was longer, it becomes harder to know what his absolute risk is. So he does have one of his subsets that's less than the 10th percentile. I think that you can think about what the risk benefit ratio is. Either the mycophenolate is doing something. If we think that this is sort of an HP or even a sarcoid type of pattern, we think it's probably doing something in terms of immunosuppression. So the question is, does he have more risk related to the use of that versus the non-use of it? I think steroids are obviously the less ideal chronic therapeutic for him just because of side effects. I think that as long as he's maintaining his white count and you're not giving him 720 is a very reasonable dose for the mycophenolate. I would probably take it off as you know that you're getting closer to transplant. Because what I'm afraid will happen is that you stop it and that it has been having some benefit and that you then accelerate his pathway into transplant. So I would make sure he's all set up for transplant before I stopped it.
Sure. Would you evaluate them at Hopkins right away or give them time to have a conversation first?
So we would start transplant workup now, in part because what we've seen is that patients who have this upper lobe predominance,
Sure.
they can go along for a long, long time where they don't become hypoxemic, so you don't recognize that the problem is getting worse. And, their lower lobes expand, so you don't really even see that their lung volumes drop all that much. But then they become incredibly dyspneic. And that, at least in our system, that's really hard to get people transplanted until they need oxygen. So we've been trying to get these patients worked up early so that we don't get into a situation where we can't get them through the process. The other thing that we found that's been incredibly devastating is pneumothoraces because they're incredibly hard to get the lung back up. And so we've had a couple of patients who have had pneumothoraces and did not make it to transplant because we could not get their lung re-expanded.
Thanks, Sonia. I got my question answered.
I have a
Let's do the next
question,
case.
Sonia. So,
Yes.
yeah, just a question. So, I've always assumed that familial pulmonary fibrosis can have all kinds of patterns, but you've seen sarcoid-like patterns as well, huh?
So yes,
That's new for me. So I have some learning today. Yeah.
So, well, actually, perfect that Athol popped on just now. What I say is that anything that doesn't look like a standard fibrotic ILD, that's when I think that the patient has a familial component because their patterns
Okay.
of fibrosis are just so unusual. So Athol, the question is, I don't know whether you were listening before or just popped on now, but the question is, can you see a sarcoid type of pattern in a familial ILD? And my answer is, we've seen everything, so it would not surprise me. This gentleman has a very, very really unusual looking pattern, but I would not, he has very strong family history, so I would not discount the fact that this is just familial ILD.
I completely agree with that,
Okay.
and I have seen a couple of patients where histologically you would call it sarcoid, but the scans were very odd with a strong family history, and they did badly. They did not behave like sarcoidosis. I mean, from what I saw on the scan, if this was sarcoidosis with family history, I would not be expecting this to progress inexorably in spite of treatment. The sarcoid patients that do that are the unusual ones with a UIP-like phenotype, and they can behave like IPF, and I think they have genuine sarcoid and they don't have a family history. That was not this case, and I go with everything you said in the discussion, couldn't add anything to it. Yes, sarcoid histology with an unusual scan can be a manifestation of familial pulmonary fibrosis.
Yeah, and just to add for everyone who was looking, I was drawing those upper lobe, I mean, just to get a sense of the size of the upper lobe. And you must have seen that in 2 years, the upper lobe's reduced by at least 1.5 centimeters to 2. That's significant progression, as Sonia had pointed out, in 2 years. So I'm hoping by the end of this session, I have the volumes done. I'm using a software to do that, and I'll just show that because it's actually very dramatic when you're looking at it this way. But brilliant, yeah. Thanks.
If you can add an addendum to that report, Bhavin, greatly appreciated.
Yes, Muthuganesh, your case. You there?
Good evening, ma'am.
Yeah, please start.
Yeah, good evening, everyone. I am Dr. Kokila, pulmonology resident from KMCH, Dr. Ramanathan sir team. I'm going to present a case of ILD. This is a 54-year-old female ward counselor with a background history of systemic hypertension, coronary artery disease, post-PCA status, hypothyroidism. She's also had a history of autoimmune ocular disease, which is Koyanagi disease, in October 2025, for which she was treated with the oral systemic steroids for 3 months. Followed that, she has been diagnosed as ILD in April 2026 in outside hospital and started an MMF from May 25th. Her autoimmune workup showed ANA positivity, whereas ENA profile, rheumatoid factor, anti-CCP were all negative. She has no significant exposure history or relevant drug history or family history of ILD. She was advised VATS-guided lung biopsy at outside hospital, and she presented to us for a second opinion. She had a complaints of progressive dry cough and dyspnea for past 6 months. Her vitals were stable with no hypoxia at rest, and her baseline blood investigation were within the normal limits. Since we wanted to reconfirm the autoimmune etiology, we repeated a complete ILD panel where rheumatoid factor, ENA profile, hypersensitive pneumonitis panel were all negative, whereas myositis panel showed strong positive for PL7. We repeated a HRCT, which showed a fibrotic ILD with no significant interval change. So radiology.
Yeah, you can finish PFT and then we will go to radiology and then your question.
Yeah, okay, man. Thank you. Lung function test was performed, which showed a restrictive pattern with DLC of 45%, and 6-minute walk test showed significant exertional desaturation. We made a discussion with rheumatologist considering her background autoimmune ocular disease and a strong positive PL7. We decided to treat as connective tissue disease. with connective tissue disease related ILD with immunosuppressants. Hence, we gradually increased her MMF dose every 2 weeks. At present, she is clinically stable with no significant symptom burden and tolerating MMF 1 gram twice daily. Although VAT-guided lung biopsy was advised at an outside hospital, we managed her as a connective tissue disease related ILD.
Okay.
But the question is whether there's a need for a lung biopsy. So can we see the scans, images? Yeah.
So that's the scan. It's an expiratory scan. So there's a little bit of an issue with the interpretation. If you just look at the mediastinal windows, there's nothing significant. She's had an infarct in the LV. I don't know if that had come up in the history, but she obviously has some coronary artery disease,
Yes,
which has
she's
been significant. Sorry?
she has a past
Uh,
history of coronary artery disease post PC status, sir.
So then she has that. So if you
Yeah.
look at the coronals, we're seeing a line of cysts along the apices and the upper lobes. She doesn't have, she's not a smoker. I don't know if she has biomass gas exposure, so I'm not able to really explain these cysts at this point in time. She has reticular opacities. There's an axial distribution. I suspect the so-called ground glass is predominantly because this is an expiratory scan, and there are quite a few areas of patchy air trapping. So there is an ILD, but I'm just not, it's a completely expiratory scan, so my hands are tied. I'm not able to further subclassify, categorize this. I can say what this is not, but I'm not able to say what this is. The other thing really is this line of cysts that we see here. And, again, whether, when you see these upper lobe cysts with a single line, you also worry about whether this is a surfactant related problem. But she is 54 years old, so I don't see that as an issue. So again, I'm not able to explain this. Too many unexplained things on the CT at this point in time. So
I think my thought is this must be a cystic myositis ILD, Bhavin. I would not biopsy. She would be at risk of
yeah,
getting.
but that's a clinical diagnosis.
Yeah,
I'm saying on a
I would not.
CT, I'm not seeing an NSIP pattern.
Sure,
I'm not seeing an
sure.
OP pattern. I'm not seeing any pattern. And I just think a lot of stuff is artifactual. So I'm
Sure.
not able to put anything together here. That's my thing.
Sonia, Athol, Prahlad, would you all biopsy? Asmita?
I think I would probably just try to get an inspiratory CT scan rather
Correct.
than biopsy her. And sometimes I think it's helpful if you explain to the patient exactly what it is you want them to do, because when they go into the scanner, they're often so nervous that they don't know that they're supposed to hold the big breath. So I think I would probably do that. I think you have a good explanation for it, and I'm not sure how a biopsy would change management. And that's generally the rule of thumb I use, that unless it's something that would change my management. Like if you said, I think this is a malignancy, and if she had a biopsy, I would treat her with a chemotherapeutic agent. That would make me biopsy, but there's nothing here that makes me think that this is anything other than an interstitial lung disease. But I'll see what Athol has to say about that.
Well, I would like to weigh up what we can say about the nature of the ILD, and I agree strongly that what I'm about to say will be quick because it's largely a waste of space till you've got an inspiratory CT scan. But I would not rule out a form of hypersensitivity pneumonitis on what I've seen. You can get cystic change in that, but not the upper lobe change. You do occasionally in HPC genuine emphysema. So I think it's all down to what you would see on an inspiratory scan, and we don't know what you will see on an inspiratory scan, but HP is in the list. I'm not so sure about a connective tissue disease. Did I switch off or something? I'm not sure that I saw compared.
PL7 was positive, Athol.
What was the PL7?
Yeah. So that's why I thought of a cystic myositis.
No, and so perfectly possible, but you're not really seeing that which you might expect in that setting on the scan we've got. So I think you've just got to take a breath in and get the inspiratory CT to make sense of it. I would not rule out an HP with a isolated autoantibody. What was the titer of the PL7? We get these rogue titers that are low grade.
It is there. Gokila, can you show that titer was there? The down should be there in the report.
Because I see this quite a bit. You get tiny titer elevations sometimes because you've got an immune process happening. And so titer levels cross the upper limit of normal. So you really want to know what the titer was, I think, before you put too much weight on it. Sometimes you'll get mutually exclusive anti-synthetase antibodies at low titer clustering.
I think it's got highlighted, and with the highlighting, I think the titer is gone.
Muthu, can you see the original report gives that? The end of the original report has it.
That's why I got fooled looking at the screen. It was blanked out as a yellow CG. So we've got yellow titers in this patient. I simply don't.
She had a ocular autoimmune disease. She had a Vogt-Koyanagi syndrome, and she was treated recently for that. With that background, she came to us.
Yes, I'm afraid if it's a weak positive, I have an open mind as to what you will conclude when you get an inspiratory scan. It's serologic promiscuity is a good term for it. You've got an immune upregulation, you start actually increasing titer levels of all kinds, and you end up calling positive autoantibodies when there are very low titers.
I think this is 33, sir. That is strong positive.
Moderately positive.
Yeah.
33 is not very low.
So I can eat my words. I'm highly nutritious, but I still want to see the inspiratory seating.
Okay, that's okay. Okay. I think,
So
we have
I
to
had
discuss.
planned to start antifibrotic also during subsequent follow-up, along with this mycophenolate.
So I think basically, Ram, get a good inspiratory scan.
Which I'll do it, definitely.
And then your question that you had on biopsy could be answered much better, which I think the consensus seems to be not to
Will that change inspiratory, like this biopsy decision will be based on that?
Apparently, according to two people, we shouldn't start making decisions without a good scan. So
that's I understand.
I think all we need to see on a good scan is that you're not being driven to hypersensitivity pneumonitis, and that you're going to say with the scan this is compatible with an inflammatory myopathy, and then I see no point in biopsying if that's what you get from the scan. The only role in CTD potentially, which is still debated, might be in rheumatoid if you're not sure if it's UIP. And there's an argument about whether to perform cryobiopsy then to find that out. But other than that, I don't think we would buy into biopsying and CTD in general. And I know some people don't buy the UIP argument in rheumatoid. So provided you've got a fairly confident CTD diagnosis, no, I wouldn't go to biopsy here for a moment.
Okay.
So we will definitely get a inspiratory scan, and there is this autoimmune antibody is positive, reasonably moderate, and there is a recent autoimmune disorder in the ocular was there. With this background, with the coronary artery disease, I decided clinically I started her on immunosuppression. Anyway, I'll do the inspiratory scan.
Sure. Case 3, Prabhu Desai, sir.
Yeah. So this is the story of a 74-year-old man from 2019 to 2026. Now, he had a breathlessness, cough, wheezing from childhood and was treated frequently with asthma inhalers and intermittent steroids. And when he presented to me, we worked up for CTD for ILD in view of clinical findings that he had crackles and also inspiratory and expiratory wheeze. There was no PGN exposure, no CTD features, and no relevant other history, occupational history. And his IgE levels were high, even ABPA, other panels like IgE specific and IgG specifics were high. And eosinophil count, absolute eosinophil count also was high. So because of the HRCT, he underwent a bronchoscopic lavage. Twice we lavaged in 2020 and later on 2023. Biopsy was not performed because of the severe bronchospasm, and a bar showed a lymphocytic lavage. The 2023, that's why he was put on steroids and mycophenolate. We'll come to the when the scans have been discussed. But in 2023, his condition deteriorated and there were shadows in the lungs, so which are localized, so like a consolidation. So he underwent a bronchoscopy, which showed a sputum AB positive and gene expert being positive, Rifa sensitive, and then we were doubting whether really it's TB. So he was again later on induced, sputum was induced, and that also showed AB positive, gene expert positive, Rifa sensitive, but cultures were negative. So the his HP panel that time was positive. His all autoimmune workup was negative. Echocardiography in 2019 was showing good LV function, no pulmonary hypertension. But to 2026, he had a well-preserved ejection fraction, but pulmonary artery systolic pressure was 65, and he used to have some sort of edema fate. So we thought about carpulmonal that time. Next. So this was his spirometry, just to show. We have done several spirometries, but just to show that the curve was obstructive and there was an almost moderate obstruction with not much significant reversibility. His RVTLC was high and diffusion was low, extremely low, and along with the KCO, which was around 78%. His oxygen saturation was 95, dropped to 75, and currently his saturation is 99, dropped to 91 on 3 liter oxygen. He is very particular about his treatment. He follows up almost a year, 1.5 years of rehab, and fairly doing active but breathless.
What is room air saturation, Prahlad?
Sorry?
The room air saturation?
Yeah, room air saturation on oxygen 3 liter was 99. And baseline when he comes without oxygen, it's around 87, 88.
Okay.
This was the course overall. He was put on mycophenolate. One physician started antifibrotics, but both the antifibrotic couldn't tolerate and he stopped it. Okay. Then yeah, because of the wheezing, and that was his main complaint, and eosinophil counts were high, he was thought of giving benralizumab. And patient was very much keen to consider for benralizumab, and hence he received almost 10 dosages of benralizumab still on, and he's significantly better as well as his wheezing is concerned, cough is concerned, and some amount of breathlessness. And the current treatment is mycophenolate, Medrol 8 milligram, that is methylprednisolone, and triple drug therapy. He was on spironolactone, Lasix. Please, previous slide. Spironolactone, Lasix. Cardiologists have started on digoxin because in the whole course, he has a pulmonary hypertension, he had atrial fibrillation, it had a right MCA stroke in 2024. He was, because of steroids, he has a steroid-induced diabetes and treated for pulmonary TB for 6 months in 2024. He had a polycythemia and OSA, and he was also using a CPAP machine very regularly. There was a carotid atheroma. Yeah, now the HRCTs.
So this is again, one of those complete googlies, because when he came in 2019, and I think I saw this 2-3 years later when he had come for an opinion, and you can basically see this is an airway-centered disease process with a lot of branching centrilobular opacities and nodules, some form of an inflammatory infectious bronchiolitis. You can see the tree in bud here, some peribronchovascular disease here, and some ground glass, but very difficult to explain. But most of the disease was airway centered with a combination of discrete dense nodules and then some ground glass here. He's also got a Bogdalek hernia, which is not significant. He had very subtle, pleural thickening. Everything else was fine. His MPA has always been dilated, minimal pericardial fluid here, some coronary disease, etc. Then in December 20, which is a year later, now we can just see them together. Everything the ground glass seems to have increased a little. The airway center disease in the right middle lobe has significantly regressed, and a lot of the other ground tree and bud in the upper lobes has regressed. He comes back in Feb 25 with significant progression of disease. And you can see that here with a lot of airway-centered stuff. Again, this peribronchovascular disease in the middle lobe has crept up. And if you didn't have priors, you would even start thinking of an invasive mucinous adenocarcinoma with this kind of confluent consolidation, the ground glass, etc. There is likely an edema component. And then he comes back almost 14 months later. And here you see pleural effusion. There's ground glass, which is a little perihilar. You still see all the airway-centered stuff. But now you're starting to see small cysts with traction bronchiectasis, some reticular opacities here, as if now there is a fibrosing component. And to me, when we see a combination of septal thickening, a fibrosing-like component, ground glass, if the edema component gets ruled out, you start thinking of an infiltrative lung disease in terms of malignancy, lymphoma, etc., amyloid, for example. So those are the things that I put forth when I saw the case, discussed with Prahlad. And I said, let's just do a FAPI PET if the patient is okay, just in case we pick up something. But the FAPI PET just showed some uptake, which means there is fibrosis because FAP is entirely picked up by fibroblasts. So we know that there is fibrosis now. But there's nothing else that gives us any sense of what's going on. The MPA diameter over 6 years has pretty much, or 7 years has remained the same.
Hasn't the
So that's where we are.
alveolar filling, which made you suspect BAC, has that reduced, Marvin?
Yes. So that component from 20, you know what, let me just get rid of the earlier ones. They're not really relevant now. So the lower lobe confluent disease has regressed, but the ground glass has increased. This peribronchovascular disease in the middle lobe has partly regressed, but not completely. But there is a fibrotic component which is now creeping up, and which was the reticular opacity was a little traction bronchiectasis, and it's not transient bronchial dilatation. It's really traction bronchiectasis at the periphery here as well. And then you're kind of worrying what's going on. And then here it's almost like it's ground glass and septal thickening combined together.
So Prahlad,
Little
what's the
lost,
question?
but yeah.
Yeah.
Prahlad,
So
what's the question?
Yeah, the question is two. First of all, really, the symptomatically, he is better with benralizumab. Should we continue that or not? Second, what is exactly is happening? That of course is confusion. Should we do any invasive biopsy? It is a bronchoscopic biopsy is not possible because it goes into a severe bronchospasm. Even lavage becomes difficult. Okay, so what could we label this disease as? With lung parenchymal and airway disease, or are we still dealing with the possibility of bronchoalveolar cell carcinoma?
I'm going to have to add saying something here, and you can shoot me down in flames. So the first thing is this is very severe pulmonary hypertension with sky-high pressures to saturation to 72%, dilated RV, dilated RA, must be about to go into crashing right heart failure. The outlook from the pH alone will be very, very bad, unless it is the sort of vasculopathy that responds to immunosuppression, but we're not looking at lupus or mixed connective tissue disease. So whatever else we do, I don't think an invasive procedure is going to be on the cards, full stop. Second, are we dealing with a single process in the interstitium? We've got a single snapshot of an alveolar filling process that went away. So always in this situation, are you trying to make one thing explain everything on the scan? Or are we mixing different processes together? If you took out that alveolar filling process, some of the words used by Bhavin might imply some sort of low-grade veno-occlusive process with septal thickening, some ground glass, pleural effusions, and that can happen in sarcoidosis. So I would be saying maybe we can't rule out that in the background there's some sort of sarcoid disorder, but you're going to have to find other things happening on the scan, I believe. And unless Bhavin can come up with a single entity explaining everything, I think we're going to have to think a bit like that. We perhaps can't weave everything into a single diagnosis. The bit I can't get my head around is that spectacular alveolar filling process that goes away. Was there some sort of infection at the time? Was there some heart failure at the time? I don't know. But if you go back and look at the hard nodules, you look at the peribronchovascular abnormalities, some sort of granulomatous progressive disorder that's wound up with fibrosis. And the plus is that you could have separate pH without it being driven from the lung interstitium if you're in that territory. But the pH is spectacular. I think you'll agree. RV dilatation, RA dilatation, sky-high pressures. That's a hallmark, isn't it, of a high risk of the pH being fatal in the fairly near future.
Yep.
That's all I can say. So please tear it apart.
Mhm.
Can hypersensitivity pneumonia and allergic bronchopulmonary aspergillosis do exist together?
Well, I thought about HP as well as a possibility. I think you're going to have to put in some other things influencing the scan. And maybe, just maybe, if you did that, you could carry the narrative that there's an HP underlying this. I think it's possible.
Okay.
But Bhavin's being a bit quiet at this point, which is unlike him when some clinician makes unbridled speculations. So I'm interested to see what he says. Have we got a single entity on the scan, or might we have more than one thing going on?
Is the HP antigen for Aspergillus positive, Prahlad?
Yeah, it's very strongly positive. Both
So yeah,
IgG
so
and
the
IgG.
same antigen can cause both diseases, that's
Both.
for sure. But
That's all
I
possible.
don't know whether we are dealing with two conditions. It's hard to say.
By any chance, anti-PR3, anti-MPO was done, sir?
Myositis panel, ANCA was done in the beginning. We never repeated again.
MPO-PR3 was not done.
It was done.
ANCA only
RA,
was.
anti-CCP, ANCA, CP. Our ANCA, when we ask, they always do with PR3.
Okay.
It's when you've got a high fungal load that you can get both an HP and a sarcoid pathway in operation, because high fungal loads are very definitely sometimes a predictor of nasty sarcoid. They get buried in a host of associated antigens. And yet you could be having something that aligns with an HP pathway. So this is, I agree it's unclassifiable, but I think we can maybe think along those lines. And so you're really separating, aren't you? Best management of pH. The sarcoid pathway could give you the pH as a separate manifestation of the interstitial disease. Perhaps a bit unusual to be saying you can now see fibrosis for the first time and saying the ILD is driving the pH at a level that it's been there for a long time. But sarcoid would give you that. I'm not sure that HP would.
Should we
Sonia,
continue antifibrotics? Would we continue the benralizumab?
I've talked
Because
about
of
cancer. Going to let somebody else make all of themselves with management in this case. And I've nominated Sonia to say something about that. Also, to tear apart what I've just said about diagnosis, please do that. Somebody had to say something.
What is benralizumab helping him with?
bronchospasm.
That's all. Because
That's
his
all.
lung
It's
function
airway
is
disease.
dropping, right?
No,
His
it's
Lung functions are dropping, but it is
it's
improving in between.
improving.
There is
It's
a
improving. Yeah.
no. He's desaturating much more.
No. It was
Look
worse.
at,
Yeah.
look at the lung function. Look at the desaturation. 2025 compared to
So he
2020.
has pulmonary hypertension, Sujit. He has got ILD. So,
He's got
this actually,
He's
He's got
he's
bad
87% on room air compared to 95% on room air 5 years ago. So that's a huge drop.
But don't you think that's explained by major RV dilatation, RE?
Correct, correct. So that's what I was wondering. What is the Bendra doing? And if Prahlad's saying it's the bronchospasm and he feels
he's
better with benralizumab, I guess it's an expensive drug to continue, but if you feel it's worth it, I'm not, I don't use too many biologics anyway in practice, but I think I'd. Sonia, any thought?
So as always, I agree with Athol in the sense that I can't put this as one disease. I think he had to have had at least two things happen and potentially three. And so, I mean, you brought up the fact that you had a gene expert that turned positive.
yes,
That's sort of amazing to me that that airway filling could be TB, but I guess there's no reason why it couldn't have been TB. So you could have had him with some primary disease that then he got TB, developed those airway filling, and now we're just seeing natural progression of whatever his underlying disease was. Um, in terms of the benralizumab, I have a very pragmatic approach to this. Is if I give a patient a drug and it makes them better, I tend to think that that's probably a good sign that I should use the drug. If I give a patient a drug and it makes them worse, I tend to stop it.
Yeah.
So I don't think that there's a reason that you have to stop the benralizumab, but I don't understand what his underlying disease is. And, it may be the other thing that's just in the back of my mind is, um, does he have some sort of immunodeficiency? And part of what we're seeing is just this really odd immune response of somebody who has childhood asthma and then develops what looks like an ABPA and then gets TB. I mean, it just makes me wonder whether he's got some sort of skewing of his immune system to start with. But beyond that, I don't have a very good answer. And my sense is that, and I'm sorry, I missed the echo results or the cath results that showed that he had pulmonary hypertension. But for sure, if he has severe pulmonary hypertension, I would definitely not try to do a biopsy.
yeah.
Yeah, he's got a dilated RA and RV, and he's got a pericardial effusion. Yeah, I would definitely not biopsy him. And I think I probably would also think about sort of group three pH therapy for him if that is something that's available.
Yeah.
So,
I really would not.
Athol, these. Go ahead.
I was just going to say quickly, I wouldn't discount sarcoid in the Hilario Noon pH paper. And it was a rogue paper. It overstated the prevalence of this, but the dominant phenotype in sarcoid pH was a post-capillary block syndrome with a form of phenoablative process that was low grade. I think some of what Bhavin's describing could fit with an element of that. I think some of the nodules and bronchodavascular change could fit with a pulmonary element of that. But I think we agree that these things don't explain that filling process. But Bhavin, please.
No, I was just saying it's only when we're in trouble as radiologists that, we need to then start leaning on you all. Otherwise, we can pretty much make up everything in terms of diagnosis. No, but, Sonia, you just triggered something when you talked of the immune issue. And I'm just thinking that if this had been a young
Younger person,
patient, we would
74
have
years
even
old.
thought of CVID um, and those in that spectrum, the CGD, CVID spectrum of diseases, because the 2019 scan is classic in that setting. So I'm just wondering, I don't know this, but do you see elderly patients in this age group sometimes presenting for the first time with CVID, CGD, etc.?
Absolutely. And we're seeing this more and more. We're recognizing both. So adult onset or age onset CVID is very common. And we're also seeing a lot of people who are presenting with ILD with IgG subclass abnormalities. And interestingly, a number of them actually get better when you give them IVIG back or immunoglobulins back. And so that's the
Oh,
one reason why I would think about it, because it's always nice to have a mechanism, but it's better to have a mechanism that you can actually fix. So I would think about doing immunoglobulins, quantitative immunoglobulins on this gentleman, and if he is Ig deficient, he obviously can get worked up, make sure he responds to vaccination. But if he has some element of immunoglobulin deficiency, he may actually do better with immunoglobulin replacement.
the GL-ILD would actually fit in because you also have that little fibrotic component and then you have the airway component. Hey, Prahlad, do you want to work him up for all this?
I will work up. I have not done any
Yeah,
immunoglobulin levels.
I think just do the whole CVID workup, because if
Yeah,
that
sure.
works out, he may just have a granulocytic lymphocytic ILD. I mean, maybe that's what it's all about.
Yeah.
That would explain things. All right. Thanks.
Yep. So moving on to case 4. This is 53-year-old lady from Thrissur. She was diagnosed as HP-ILD in 2018. There were no history of any other comorbidities. She presented with, she comes with on and off exacerbation. This time she was looking very sick and I have to admit her. We have recently done her immune CTD profile once again. It was done in 2018, but just for the knowing whether it is changed over a time. So she has ANA 2+ fine speckled. Her RF was positive, not very highly positive. This is her ANA profile. And I think, Sandeep, you can say your comments. Do you think anything significant? If you are there. Otherwise, we found that it was
No, madam, nothing significant.
nothing significant. Yeah, she's this is over a period of time, her PFT. So one thing which I would like to say is, if I can brought the previous slides from my another presentation, in 2018 her lung capacities were around 64 to 68%. In 2021 she developed COVID, and after COVID it became 44. From 44 it never recovered to 60%. So the COVID pneumonia, though she was not admitted in ICU, but I can see the results, and she started desaturating also in 6-minute walk test only after that COVID. So this 96 to 60 76 and all, she was always maintaining above 90 till she developed COVID. So that is one information which I would like to share, and with that we will see the HRCT of this lake.
Congratulations on the DLCO. That's the lowest DLCO I've ever seen captured at 8%.
Maybe she could not hold the breath, sir. She was not very
I do believe
willing.
it. I do believe it. But it's a new record for me. 9% was my previous lowest in my medical career.
Okay, so I've got both the scans. This is 23, and you've got reticular opacities, axial distribution, mid and lower zone predominance, traction bronchiectasis, no honeycombing, subtle ill-defined non-branching centrilobular nodules, if at all, little bit of air trapping. So non-IPF pattern, we could call this a BIP pattern and say that this is likely HP or any other etiology that comes with this. Then there was a CT with a CTPA done in June 26. The CTPA is unremarkable. This one has an inspiratory expiratory scan. I'll get rid of the expiratory. So we have 2 inspiratory scans about 2.5 years apart. There's clearly progression of disease. The pattern remains the same. So irrespective of etiology, we are dealing with a progressive pulmonary fibrosis, and it's it doesn't have classic BIP pattern features. I would just actually call it non-IPF, unknown etiology, consistent with whatever you say is clinically the diagnosis, but it's progressive.
So
That's where we are.
she had PGN exposure in 2018 when she presented first time, and
And
that is why.
everyone has pigeon exposure in
No,
India.
in
What?
Kerala.
I'm just
No,
kind
sir,
of
it is
getting.
very uncommon in Kerala because we don't have that many pigeons.
Okay.
Seriously.
I mean, in Mumbai, it's like, everybody has
Sure,
pigeon exposure.
sure,
And,
sure,
and
sure.
you know,
No, no,
unless you
no.
live on the 50th floor of a tower or something. So,
Okay, okay, got it.
They can reach on the 50th floor also.
can
Yeah.
they? I'm not aware. Yeah. How high can they fly?
Pretty high, pretty high. They get onto
Yeah.
terrace and they're onto these pools on the terrace and everywhere.
Oh,
Sure,
okay. All right.
sure.
Yeah,
I'll
you have a pool on your terrace, Sujit. So clearly, you
Okay.
you have experience with that.
Okay, if you will stop sharing, I'll share my questions, sir. Yeah, thank you. So the questions are like we did FOB and BAL this time, and there was I'm not sure about the lymphocyte count, but it was not TB or anything. This is the medicine she was on. She is not willing to stop that prednisolone, which was started in 2018. MMF only this dose she can tolerate. And my this particular time we want to know that PPF background HP sudden progression over last few years, and what should we do? Should I add antifibrotic? Should I just directly refer? I'm not sure whether they will be willing for even transplant. She just wants to go on without transplant. That is what I can understand. Yeah.
So just to clarify, you did a BAO with a DLCO of 8%. You
Yeah,
obviously
we
used to carry it off. So
yes. Yeah, we did.
right. Well, there's nothing like courage, I guess.
Yeah. Mhm.
Can I just ask, was the pulmonary artery enlarged on CT, and is there evidence of pH? You've got a DLCO of 8%, a KCO of 36%. There are two possible explanations. One of them is this incredibly fine infiltration that's dragging the gas transfer down more than the volumes, and you can see that. But the other is there's major pH with this desaturation, DLCO of 8%, KCO of 36%. Was there pulmonary hypertension? Was there an
No,
echo?
so MPA is 25 millimeters and RV is less than LV in that. There's no evidence of
This
pH.
is just the phenotype. You've got this incredibly fine infiltration everywhere. And we do know that happens. It drags the gas transfer down sometimes with much lesser effect on volumes. But boy, is that an effect to drag the DLCO down to 8%. And you tend to buy into that most of all with HP, don't you? Where you've got very diffuse, fine ground glass, which is dragging the DLCO down. So it's a feature that might favor that.
I mean, you want to know about further management, Asmita, that ANA was 2+, you said, right? You got a
Yeah,
block.
yeah.
You got a
KNA2
block.
plus.
You got a
Yeah,
block.
yeah.
And,
That was not significant, Sandeep told, na,
and
sir?
her myositis was also negative.
Myositis is also negative. Yeah.
Okay.
So just to follow up on, is there a role for an antifibrotic in this situation? Um, my sense is that when you have a patient who has some sort of ongoing stimulus, whether it's autoimmune or whether it's something external like HP, that their lung has the choice of either repairing normally or fibrosing. And I think that there are many things that are suggesting that she's moving towards a fibrotic phenotype, particularly with the drop in her lung volumes. And so my inclination would be to start an antifibrotic at this point in time. And I think that it is an imperfect intervention in the sense that it's not going to, like, whatever is driving this has not gone away, whether it's autoimmune or whether it's external. But at least what you're going to do is potentially slow down or reduce the rate at which it's going towards fibrosis. And I think that, at least in my limited experience after the InBuild trial, was that the patients who did best in my group were the patients who had HP, who had some element of normal repair. And those were the people who really actually benefited from the antifibrotics.
Sonia,
Asmita,
in Hopkins, sorry, Prahlad, just one question to Sonia. If she refused transplant, as Asmita said, would you consider rituximab at Hopkins for her?
Um, If I thought this were HP, which is sort of the direction I think it is, I probably wouldn't give Ritux. If I thought that she had an autoimmune disease, I might think about giving Ritux. I just I don't quite have a sense with her of what is driving this, but my inclination from what I just heard is that it's more along the HP pathway. And in that sense, in that context, I'm less commonly using Ritux. I don't know about you, Athol. What are you doing?
No, I would mirror that, and I also agree that we've got to have an open mind. This could be an autoimmune problem, but I think the phenotype is more typical of HP. What I would do is go back and say what immunosuppression has been had for how long. So, in this situation with a DLCO of 8%, the next question is whether there's something reversible because there hasn't been enough treatment for long enough. And that would be my first step. 8% is desperate, and anything you can do to actually improve it. And I agree that adding an antifibrotic drug, I mean, you're going to have to empty your arsenal in this case, I think. There's no point in waiting for progression in spite of management because she'll be dead with a DLCO of 8%. So I think you can certainly put that in, but I would also be reviewing, are you sure you've had enough immunosuppression for long enough? And going back to that, and I'm not sure I got the package completely.
I think it's five prednisolone and
500
1 gram of
BID.
MMF.
Yeah, she's on a very low dose of MMF, but I guess that she's only on that dose because that's how much she can tolerate. The other question I have is, do you have Myfortic? Do you have access to that? It's not
Sodium, the
molecule, it's
sodium salt.
We have.
we found that some of our patients are better able to tolerate Myfortic than Mofetil. So you may want to try that. And then the other option would be to transition her completely and put her on something like azathioprine. And again, it just seems to me that there's very variable who can tolerate what. But I think that if you're just looking for if you're just looking at that kind of immunosuppressant, you can also make the switch to AZA.
I think the other thing I
I
would
think
say is there a case in this desperate situation for a quick trial of pulse methylprednisolone? So actually, you've got to do something to rescue a DLCO of 8% and that very extensive abnormality on the scan. I don't think a short, sharp burst of steroid, you're not committing to that in the long term. But the crime would be to miss an opportunity. So I'd be awfully tempted to give that a whirl. Sonia?
Prahlad, you were going to say something?
yeah. No, I thought we continue mycophenolate and add additionally azathioprine small dose, 50 milligrams a day. Probably
Myco and AZA.
together.
Yeah,
But
I would
what
probably
about
switch rather than add, but I also I actually really like Athol's strategy because if you gave her, a 3-day pulse of 500 milligrams of methylprednisolone and she had significant sort of, symptomatic relief with that, that would definitely push me towards intensifying immunosuppression. So I kind of like that strategy.
Okay. So when she was admitted, she received 3 days of 125 and she was better. I felt that was an infective exacerbation rather than anything because anytime she develops infection, her values goes very down. So I was actually thinking of reassessing her everything, CT scan also. But I have meanwhile started nintedanib because I was worried about her fibrosis, which is worsened so fast. So
I'm
I will, yes, sir.
But she's getting these recurrent exacerbations in the last 5 years, Asmita, since COVID,
Yeah,
without any
not very
loss.
frequently, sir. It is hardly once in 6 months, but this is like
That's
one,
all,
this
no?
is second admission since COVID.
So that's
as
2 exacerbations a year since the last 5 years with a stable vital capacity. So she's there's something, I don't know whether it's viral or whether
Yeah,
you
something
try
is
the
going on.
steroid
Yeah,
and push up her immunosuppression.
sure.
me, you just said something very important, though. You gave her a bit of a steroid. She got an improvement.
She improved.
You're not sure if that is actually an action on the disease process. Yes, it could be an infection, but why would the steroid improve an infection? So I would say you've got ample grounds for saying that there might be a very important role for immunosuppression. And if you were in two minds before, and you give her a relatively low dose challenge compared to a full methylpred challenge, and you're seeing a signal, it becomes even more important not to miss an opportunity. Because you don't know the improvement was just infection, you're just concluding that. But it could also be you were treating the disease process itself.
Okay, we'll move on to the next case. So this is a gentleman who I have not seen. This patient came with CT scan and CD. So he is a patient who was chef in UK, type 2 diabetes, hypertension, ILD diagnosed there 3 years before, evaluation for dyspnea, and IP admission outside hospital in January 2026, which required mechanical ventilation and tracheostomy. And before he could recover, he was just on and off with another bout of infection and everything. So this is his history: mechanical ventilation in January 26, then tracheostomy, then decannulation in February. He received 500 milligram of prednisolone for methylprednisolone for 3 days at the time of that admission, then developed stroke recently and has received vaccination as per the protocol. The relatives came to me telling that there is a shortness of breath and fever and body pain, exposure to charcoal fumes. That is the only exposure which he has got. These are the reports which has been done outside. There was a moderate pulmonary hypertension, nothing else significant. And HRCTs we will discuss. Yeah. I don't have PFT, I believe. Yeah.
We have two scans, February and June 26. The February scan, you can see here, is extensive traction bronchiectasis, some honeycombing in the bases. Uh, it it looks as if there's some, consolidation, but I think it's just because the inspiratory effort in the lower lobes is less, or maybe there's some acute exacerbation there. But there's pneumomediastinum, and the upper lobes show a little bit of ground glass here. There's downsloping of the fissures, and you've got a lot of this proximal bronchiectasis. So this is what you get often with connective tissue disease, and you could say that this is a predominant NSIP pattern, but perhaps tending towards UIP and acute exacerbation in the lungs. When we look at the next scan, which is about 4 months later, the basic pattern remains the same. But now we've got these peribronchovascular areas of ground glass and consolidation, which are either infection or acute exacerbation again. The pneumomediastinum has regressed, but if you look at the upper lobe and the lingula here, there's progression of fibrosis. There's honeycombing, there's traction bronchiectasis, and that's actually increased, almost as if some of this ground glass has now been replaced by fibrosis. And some of this as well has been replaced by fibrosis. So, the exudation, organization, and then healing with fibrosis pattern. But in that case, this also then fits into a rapidly progressive ILD phenotype, if you accept that as an entity, in which case, again, you would think of an inflammatory myopathy as an underlying cause, but that's kind of where we are.
And just one other thing that I would point out is look how small his lung fields are. I mean, they're just tiny.
Yes. Yes. I think that is what I told them, that even in the first CT, I also felt that this much of feeling can be because of infection. And this time also, I told that if they have not started, Ceptran can be given. Patient is on the promising part was, in spite of this bad CT scan, he is only on 1 liter oxygen and maintaining saturation. That is what the relative told. I spoke to the doctor treating also. He also said that 95% on 1 to 2 liter oxygen. Minimum ambulation, he desaturates to 70%. Presently, patient is on nintedanib 150 milligram BD. So he's not, they won't take him for transplant. He's very sick for that also, but anything to offer. like we can do anything more than what we are doing.
I mean, when I see an image like that, I definitely think about the patient having a form of autoimmune myositis, with a very reduced lower lobes, with lots of kind of, the sort of exuberant honeycombing at the bases and almost the pancaking of the lower lobes. I don't know how much more workup he's had. I think I saw that he'd had an ANA
Yeah,
and
I did not see. Yeah, I did not see myositis profile. You are right, and he developed pneumomediastinum also, which goes in favor of. So
right.
SAE 1 plus, yeah, they have sent, but I have not seen the reports like the way we see titer and all.
I might redo that and also just send a CK and aldolase on him. And I don't know whether he has, it sounds like you haven't actually met him physically, but it'd be also very interesting if he has any muscle weakness. Because the reason that I think we see the diaphragms elevate like that is because there's actually diaphragmatic weakness. And so if he has other forms of systemic weakness, or if you do a thigh MRI and he has inflammation in the muscles of his thigh, it would give you a reason to aggressively immunosuppress him for an underlying autoimmune disease. But I think he is somebody who needs probably pretty aggressive therapy at this point in time, because I agree he's sort of falling into that category that looks like he's, even if he's not a rapidly progressive, he is progressing down what looks like an inflammatory pathway. And in that context, I think nintedanib is better than nothing, but it's not the right drug. And so I would add immunosuppression if I had any inclination that this was autoimmune.
Sure.
I completely agree. By the way, I don't think I'd use methylpred in 3 doses necessarily, because I suspect that you've not got an element that will respond spectacularly to that. So probably it's a fairly aggressive approach, but more along the lines of this is something where you might include rituximab in a regimen or not. I think I'd be inclined to think about that. And maybe with mycophenolate. Of course, you are going to go on and get those tests done, but let's suppose you got equivocal signal, but you've got that CT phenotype there. I think it would be reasonable to be embarking on a management as for that entity if you are left in doubt. You're not sure. Because again, the philosophy would be it's a crime to miss an opportunity.
Sure. So this is the third and last case from my side, and this is about one health administrative worker. He is 59 years old and he was diagnosed as right renal mass. That was also an incidental finding. And during that incidental finding, they caught up that there was some minimum interstitial lung disease, which he was following up. And now he has come to me. So it was the renal mass was clear cell carcinoma for which he was operated. And presently he has only complaint of mild cough with intermittent breathing difficulty and he has to clear his throat. Uh, Recently loss of 12 kilogram in 2 years. He's telling it was intentional weight loss and non-smoker, exposure to construction work dust for last 4 years. His father passed away because of lung cancer. Vitals were stable. ANA is 1 plus positive. There is AG reversal mild, and then he has ANA profile of nucleosome 1 plus, myositis profile relatively negative, with vital capacity of 58% and FEV1 over 70% with ratio of 102, DLC of 66, KCO of 86, and he did not desaturate, covered 480 meters. The reason he came were two questions: whether the biopsy is necessary and does it fit into HP pattern, because what he told me that where he stays almost opposite house, there is a rubber processing plant or factory, and whatever he inhales is always like that, and that is for years together. CT.
So there's no HRCT. It's just part of the CT chest, abdomen, pelvis of the renal cell carcinoma follow-up. But that's fair enough. We see reticular opacities, axial distribution, mid and lower zone predominance, a little bit of a hexagonal pattern in the lower lobes. So this fits in, I guess, with a non-IPF BIP pattern suggestive of hypersensitivity pneumonitis, if that's your clinical diagnosis, but kind of fits in really well. We don't have expiratory scans. We don't have anything else. There isn't a lot of ground glass. It's predominantly just reticular opacities, and that's about it.
I think then, do we need to do anything more or just treat as HP?
I might be inclined to do a BAL in this patient, just to see if you get a lymphocyte dominant BAL. Because the other thing that I worry about in somebody who's had a recent malignancy is that he has a paraneoplastic syndrome. And so, if you saw, say, a polydominant and you thought it was sort of an autoimmune, you had an elevated antibody, I would worry that he's got a paraneoplastic syndrome. But and I'm sorry, I couldn't remember exactly which one was elevated, but thank you. I am not familiar with what a nucleosome antibody actually recognizes and what it's associated with, but that would be the only other thing in my mind. And the reason I would care about that is because you would go in such a different direction if that's what it was. Now, I have to say, all that said, he had a very fibrotic appearing CT scan rather than an inflammatory appearing CT scan, which also makes me a little bit perplexed about what he has. And so, I think I would like to get a little more clarity on what his diagnosis is before I make it a recommendation on therapy.
Would you want a
Sandeep,
fresh scan, Sonia?
If that's feasible, I would do it. Again, I mean, often there's a very small primary when you get a paraneoplastic, but a clear cell carcinoma of the kidney is not a trivial malignancy. So I would also, I think that that's a very reasonable thing if that's an option to get a PET scan.
somehow our urologists are not quite fond of PET-CT for following up or diagnosing renal malignancy. I'm not sure why, but they don't agree for that. Sandeep, did you see that nucleosome? Do you think anything coming out of it?
No, often 1+ nucleosome is seen as false positive, and it doesn't mean anything in this patient.
Sure.
And
If it was a higher titer, it would mean something. I've just looked it up online. In renal cancer, it is a marker of paraneoplastic events. So at the very least, it might be worth repeating the titer, I guess. But it sounds like it's in the same territory as serologic promiscuity with other low titers.
Do we need to treat it? Because he's not symptomatic. Other than cough and PFT wise also, I'm happy. Like
His father had a bronchial lung malignancy.
lung cancer.
So
He
I
has
think we have to
renal
be
cancer.
renal cancer. We can. So I think we should can do a
Possible.
good scanning first, HRCT, repeat, and maybe close observation.
Sure.
I'd like the idea of initial observation. The DLCO is touching 70%. Spirometries, the abnormalities on the CT. Well, you're going to get a proper scan, so you'll get a better idea of, I guess, if there's more there than you're seeing on the current scan. But it's not unreasonable.
And no COVID, right?
Not COVID, sir. This is
No prior. No, he didn't have COVID
so
in the past.
I asked him whether he had COVID. So he told that the entire family had and they managed at home.
So no scans. Okay.
Nothing. Yeah, nothing to suggest.
Because we're now seeing some patients with unusual patterns, and then when we ask for the old scans during COVID, you find that it's the same pattern that has now become fibrotic and things like that.
So you want me to do PET-CT because in PET they won't do HR, sir. So I can do PET. If it is,
But you'll also need a good scan to anyway document and then
You need a
follow up.
scan.
So
Yeah, you need a fresh scan, Asmita. And if he's losing weight unprovoked, continues to, I'd get a pet.
I would, okay, I'll speak to them.
So
Thank you.
in renal cell carcinomas, we often do FAPI PETs rather than FDG PET because unless you're dealing with skeletal mets or lung mets, so there's a lot of this subdivision that happens with RCC follow-up depending on what you're looking for. But if you don't have anything specific, then a FAP is better because it'll pick up the RCC nodules better than an FDG. But if you've already got lung and skeletal mets, then it doesn't matter. Then FDG is good enough. So
Okay, sir.
since he doesn't have anything else, then a FAPI PET would be better than an FDG PET. That's all.
Okay, sir.
What is FAP-like bovin in sarcoidosis? Does it pick up sarcoid inflammation as well as FDG PET does?
So FAP picks up fibrosis more than inflammation. And so in sarcoid, you'd prefer an FDG PET to a FAPI PET.
Yeah, okay.
Okay, last case by Dr. Sonia. Over to you. Yeah.
Yeah. Hello, good evening. So this is a 43-year-old lady. She was not symptomatic at all. Hypothyroid on treatment. Apparently, her occupation is she is a baking instructor. So she conducts a baking classes 3 times in a week. She goes for a routine annual checkup on which her X-ray shows some abnormality and for which they got a CT scan done. Actually, on walking, she desaturated, but though she was not symptomatic, she had clubbing. But when we asked her, she said that she has these nails right from her childhood. And on auscultation, there was no significant sounds that we could hear. Blood investigations were absolutely normal. Her ANA was normal, profile was normal, ANCA was normal. Her HP profile showed a significant positive for pigeon proteins, feathers, and droppings, and borderline positive for fungus. So we had a visit to her house recently where her ceiling had a lot of blisters and cracks, and she had some molds in the ceiling because there was a seepage of the water from the top level of the apartment. Can we go ahead, please, Asmita? Her echo was normal. And these are lung function. So unfortunately, there's a typographical error. On 16th of March, her FVC was 32%. And at that time, the DLC was 20%. 25th of June, her FVC was 35 and DLC was 36%. Can we go ahead? Can we have the CT scans, please, Bhavin? So she underwent a CT scan first in March, and then she came to us 15 days back, and we got that repeated because she was advised treatment and she refused to take steroids, and she was probably hopping all the pulmonologists to find out whether she has some other alternatives compared to steroids.
Yeah.
So, but just a snide remark would be she can go to a homeopath and she'll get the steroids without being told she's getting steroids. So
She went to
win-win
Ayurvedic
for
also,
everybody.
Bhavin. Yeah, so she's gone to Ayurvedic.
Yeah, same thing. So she'll get. Well,
the thing is,
Ayurveda,
Bhavin,
unfortunately.
Six
Sorry.
months back, she had gone to Palitana. You might be aware of it, and she climbed
Lots of pigeons.
She climbed
She did.
3,500 stairs, and she said that I'm not symptomatic at all. And this was an incidental finding.
I was just saying with Ayurveds, you will get steroids and lead. So good.
Yeah.
I mean, you can learn a little about lead poisoning as well. All right, so we've got 2 scans. Both of them look the same. You've got reticular opacities with this bronchocentric upper lobe distribution, ground glass, and a lot of non-branching ill-defined centrilobular nodules. A lot of this 3-density sign in the lower lobes. Are pretty much what you would get with a BIP pattern and would call HP unless there was some other etiology, and no significant change in 3 months. MPA diameter is 24 millimeters. RV is not dilated. There's no significant adenopathy. Everything else is otherwise good. There's nothing off at all. Yeah.
So we could not do a bronchoscopy and a biopsy because her FVC is 32 and 35%. Now, the question is, she is not symptomatic and she doesn't want to take steroids. So what should we do in this case?
You did a BAL?
She is refusing all the procedures, Sujit.
Well, then why has she come to you?
Because she wanted to take an opinion. The 3 or the 4 pulmonologists said that you have to start a steroids. And she, as I said, she's hopping. She's doing. So what should we do? I mean, in this case.
So the interesting question is, what is her trigger? Because, you've talked about mold, she has a pigeon antigen, but you also see people have hypersensitivity to flour components. And so is it because she's baking that she actually is getting this?
Yeah.
So
Yes.
obviously, the first thing is, can you mitigate her environment if you think that this is an HP? It looks very inflammatory now. It doesn't look like it's fibrotic yet, but I imagine that she has some microfibrosis. So I guess the question I would have is whether you can mitigate her environment. And one of the things I would do is, and I'm not sure whether this is feasible, is have her stop doing the baking for some period of time, like a month, if she can take a month off from work, and just see if her PFTs improve. But I think that you're kind of stuck with the idea that you're going to have to give her some sort of immunosuppression. But I agree, you don't have to give her prednisone. You could start off with something like mycophenolate. There's no reason why she has to have steroids up front. But I do think she's going to end up needing something that is anti-inflammatory. So I do think that she's going to need, some sort of immunosuppressant. I don't know what your thoughts are, Athol. What are you thinking?
Make a deal territory. Sit her down. If she won't take steroids and she won't have tests, you may find she won't modify her lifestyle, and then you have to make a deal and say, what can we do in that case? Mycophenolate seems to me an excellent first step. If she won't take steroid, there's no point in bullying her. She just won't take steroid. You accept that she won't follow that instruction. So you actually find an instruction she will follow. And I think I'd plead with her to have methylpred briefly as a starting point, but I don't suppose I'd get far. And basically, it's a combination of what is best you can give. I think with a DLCO of 24 and 36%, it's not that she'll end up needing something. She needs something now. And especially if she's not going to be able to modify her lifestyle or will choose not to do so. And so we can't advise on management till you've had a make a deal conversation and you've extended it to not just, I won't take steroid and I won't have tests, but what am I going to do about triggers? And until you know that, it's difficult to be definitive, isn't it?
So I'm curious, I don't know if there's any literature out there, and I'm curious if you've had any experience with this. What's your thought about air purifiers in somebody who presumably has an indoor exposure as opposed to an outdoor exposure?
I think it's a very neat idea. I have to say this is an extreme of make a deal where each step you might want to take to help her is a step she turns down. So I don't suppose I've been in a situation of having to go there in the UK to this point. But I think it's a neat idea, interested in what others think on that.
So the evidence is very low, right, Sonia, for air purifiers. And I know we had a debate in a conference recently, and the person against air purifiers won it hands down because there was no evidence. But
Yep.
and I think he referred to a lot of the guidelines which also recommended very little evidence for these devices. One in 10 of our patients in that age group, Sonia, that's Sonia and Baroda, between the age of 25 and 40, refuse steroids. So mycophenolate is how we go, and they do reasonably okay, but they are symptomatic. So obviously, this lady is ready to tolerate symptoms. And then I think what Sonia said is right. Ask her if she'll stop baking for a few months and see if that makes a difference to her lung function, because her lung function is low. So you really need to.
Mycophenolate, Sujit, because she was absolutely no for steroids.
Right.
So we already started her on a mycophenolate, and for that we could convince her. And we have actually asked her to stop baking and take the classes because she's an instructor. And I've asked this husband to, at least change the house for some time till he gets all those things rectified. So this is what I mean. I just wanted to know whether I'm on the right track or not at this point, because I mean, doesn't make any sense in not giving her anything at this moment with an FSC of 36 and a DLC of just 20%.
There's no right track here. As Athol
Yes.
said, you got to make the deal, and that deal is the right deal.
I would come back to the suggestion of a purifier, though, because the evidence and guidelines supposes that you have patients who are actually generally collaborating with best management. And if you're going to have trouble making a deal, you're going to have trouble clearing the environment. And so you're not going to get evidence for that based on studies in people who do collaborate in management. And you've got to do something extra if you're not going to be able to make an environmental deal. So the something extra is not going to be captured in a guideline. It's not going to be captured in an evidence base. But based on common sense and logic, it seems to me a great idea. You just have to work with what you can work with, I guess.
Sure, sure.
But Sujit, about air purifiers, I mean, Athol comes from a place where central London has an AQI of 2 and 5 these days because
Yeah.
of the way they've managed things. In Mumbai, if I get an AQI of 75, I'm happy. So,
Yeah.
I mean, and I'm sure it's the same in Baroda. You get an AQI of 40, 50, you're happy. On a very bad day, you go to 200, 300, and we live there. So any air purifier is good because the guidelines don't work for India. They are made for Western countries. I mean, you
Well, I
have to
know,
use
I
air
know,
purifiers,
but I
No,
know
in general. So in a person,
Bhavin, Baroda is
but
surrounded by industries altogether. Baroda, the city
but
is in
exactly.
the middle,
yeah,
and it's completely surrounded by the industries.
but then
Sujit, some of the air purifier
yes,
who works with the piezoelectric effect, okay, they destroy fungi in the room. Okay, so I think uh, they are useful, especially with restricted overall activity to room only,
yeah.
elderly people, etc. and all that.
So
So they work actually.
Alok Nath gave a great presentation from SGPGI on this issue. And he also showed that there were some air purifiers that were actually harmful. And he showed some studies on that as well. And no evidence to show that air purifiers help at all. And
But
I think,
air purifier
but
cleans
I
the
agree,
environment.
absence of
You can see the
evidence.
filters which showing fungi.
Yeah, yeah,
So there's many different types of air purifiers, and I
sure.
think the ones that have been associated with harm are the ones that use ozone. And so
Yes,
what is
yes.
much more common in the US now is just a HEPA filter with an activated carbon filter. So it reduces, the HEPA filter pulls out the small particles, the carbon filter pulls out a lot of the volatiles. And so it doesn't generate anything, it just removes. But
Right.
again, you have to have one that's appropriate to the size of your house. They're thinking about this a lot now for asthma in inner city children because a lot of the exposure is actually happening in their home. And so it's just something to throw out there. This sounds like somebody
So,
who is not going to be willing to do a lot of things, but if you put it in the context of this might help everybody in your house breathe cleaner air, maybe that would be something that she would be able to resonate with. So,
sure.
all right, I've got to hop off for another call. These were great cases. Thank you so much for letting
I
me.
have a question for
Thank
Thank
you.
Sonia.
you.
One
And I
question.
think
I have one question. If the patient, not this patient, any patient who's, FSC is 35%, but giving them steroids or a mycophenolate, if the FSC improves over some time, are we justified in doing a bronchoscopy, a lavage, and a biopsy in that patient if it goes to 45%?
The trouble is you may suppress the signal that you're hoping to use to diagnose at that point. So if you get a striking response to steroid, now we've shown that more traditional lower doses don't influence BAL findings in HP, but in this case, you would presumably be looking for a major response. I mean, you could still do it, but I would have said that you're pretty much certain what the diagnosis is actually here. The question is what the trigger is, not what the diagnosis is. So I'm not sure that it's necessary to go back. And what would you say if you did the BAL and you didn't get a lymphocytosis? You'd say the diagnosis is still HP. and we're not getting a lymphocytosis because you've had a great response. If you do a BAO and get a lymphocytosis, you'll still say it's HP.
Bye, everybody.
I think that's it
Okay.
from our side. And
Can
next,
we?
next meeting is in 24th July. Yes, sir.
No. Thank you, everyone, and
Okay.
bye.
Thank
It's
you.
6:30, so
Thank you.
time to sign off. Bye.
Ms. Mita, stay on. I just want to ask you something.
Yes, sir. Can we make it offline, Arvind?